This is a dictation on patient Elias, E-L-I-A-S, Frank, F-R-A-N-K, initial E. Please address it to Dr. Martiniuk, M-A-R-T-I-N-I-U-K, hyphen K, Kingdon, K-I-N-G-D-O-N, initials KLC. Paragraph, date of visit, MAR 27/19. DGX, seronegative, inflammatory arthritis with recurrent dactylitis, stop, possible spondyloarthropathy. Paragraph, meds, Celebrex, 200 mg, BID, paragraph, interim history. Frank had laboratory investigations done which showed ESR 13, CRP, CRP 6.7, negative Hep B and C serology, normal calcium, phosphate, 25 hydroxyvitamin D at 78, normal ACE level, negative RF and HLA B27 serology, normal serum TSH, urate 382, creatinine 98. Stop, X-rays of his hand showed questionable erosion at the radial base of second proximal phalanx. Stop, and mild OA, first MTP of the right foot. Stop, he is quite symptomatic and still has evidence of dactylitis of the left index with tenderness and swelling of the left second DIP joint. Also his left first IP is tender. Paragraph, impression, inflammatory arthritis, likely from spondyloarthropathy group. I referred Frank for MRI of left hand to investigate it further. Stop, it seems that he has not responded to Celebrex at all, and therefore he will stop it. I suggested trial of sulfasalazine, 1000 mg BID. Stop, benefits as well as possible ASEs were discussed. Stop. He will have follow-up blood work in May, and I will review him again in July or sooner if any problems arise. Panjeta, P-A-N-J-E-T-A, Jasvinder, J-A-S-W-I-N-D-E-R. Please address it to Dr. Vora, V-O-H-R-A. Initial A. Thank you very much for referring Jasvinder, who is 71-year-old female. Who is 71-year-old female. With respect to her rheumatoid arthritis. Stop, since I've seen her last in June, she has been diagnosed with cryptococcal pneumonia, and also with cryptococcal pneumonia and pulmonary fibrosis. Stop. She is currently on treatment with fluconazole. Stop. She has been diagnosed with rheumatoid arthritis. In 2010, and is known to be strongly RF and anti-CCP positive. Stop. She has been treated with combination of methotrexate and Plaquenil and responded to that therapy quite well. Stop. She also has osteoarthritis and underwent a right TKR in May of last year. Stop. And paragraph, due to pulmonary fibrosis, she has been taken off methotrexate. Stop. This has not, however, caused any flare-up of her rheumatoid arthritis. Stop. She is on fluconazole since November of last year, and the treatment may still be ongoing for a few weeks. Stop. And paragraph. With respect to rheumatoid arthritis, she did not have any other complications, and she also has not suffered any and she also has not she has not had any other complications related to methotrexate. Paragraph. More recently, she was found to have L1 vertebral fracture, and her BMD showed T-score of -1.5 at the spine and -0.6 at the hip. There has been evidence of progressive bone loss since 2013. Stop. She also has history of HTN, type 2 diabetes, and GERD. Stop. Panjeta does not speak English, and she has difficulty coming to my office for ongoing care. She is lacking family support and has been usually brought in here by her neighbors. Paragraph. She is not experiencing right now joint pain or stiffness. She has some limitation in right shoulder joint, where she is known to have OA and rotator cuff pathology. Paragraph. Meds. Fluconazole 400 mg per day since NOV 15/18. Plaquenil 200 mg OD, doxazosin, ferrous sulfate, bisoprol, ASA, Janumet, irbesartan, hydralazine, Pariet, and Norvasc. Stop. In fall of last year, she was going to start therapy with tofacitinib, but only received one dose. Only one dose of it, and therapy has been stopped due to cryptococcal pneumonia. Paragraph. Allergies. None. Paragraph. P/E reveals limited mobility in the right shoulder due to discomfort on internal rotation, scar after a right TKR, and no evidence of either tender or swollen joints. Paragraph. Impression. Seropositive RA. She is in remission on Plaquenil, and at the present time there is no need to consider any other additional therapy. She should also not return to tofacitinib until her infection is fully eradicated, and in case she flares up. Stop. She was referred today for blood work as well as x-ray of the entire spine to check if there are any vertebral fractures in the thoracic spine. Stop. She was given prescription for Prolia for treatment of osteoporosis, and hopefully she will start this as soon as possible. I would like to review Jasvinder in about 6 months or sooner, if she has flare-up. Stop. Thank you for referring her for consultation. Patient Harford, HARTFORD, Flora Jane, FLORA-JANE. Please address it to Dr. Sao, CAO, initial Y, and CC Dr. Ginty, GINTY, initial A. Thank you for referring Flora Jane, who is pleasant 75-year-old female, with respect to possible temporal arthritis or some form of connective tissue disease. Paragraph of Flora is known to have history of severe migraine headaches since age 12. For over the last month, she had at least 15 headaches, and they are usually associated with prodromal aura in form of flashing lights for about 30 to 45 minutes prior to development of headache. Usually resting and being eases off her headaches. In December and early January, the nature of her headaches changed. In addition to her usual migraine headaches, she has been experiencing also temporal headaches, particularly over right temple. Temporal arthritis has been suspected, and she started prednisone 40 milligrams per day and had a right temporal artery biopsy, which did not show evidence of GCA vasculitis. Her blood work prior to starting prednisone showed ESR 62 and CRP 67, as well as positive ANA and anti-DS DNA serology at 19. She has been tapering prednisone, and currently it's on 10 milligrams per day. Over the last few months, she has been experiencing a variety of symptoms, including extreme fatigue and increased sleepiness, and also achiness in her hands with possibly some swelling. She has no history of rashes and photosensitivity, and no history of recurrent mouth or nasal ulcers. She has been experiencing hair loss for several years. She has no history of serositis, seizures, psychosis, or thromboembolic complications. She suffered from some stomach cramps, but has no history of peptic ulcer disease, gastritis, or heartburn. She is known to have Raynaud's for at least 5 or 6 years, affecting fingers and right ear. And she also has a dryness in eyes and mouth for several years. Stop and paragraph. And paragraph. She has poor balance. She has also history of she also has history of dizziness, usually related to postural hypertension, which whenever she tries to quickly stands up. She was treated, however, for true vertigo about 5 years ago, but diagnosis has not been clear. Possibly it was benign positional vertigo and definitely not Meniere's disease. She has been quite unsteady on her feet and fell twice over Christmas. She has no history of peripheral insufficiency fractures, but has been found to have 2 vertebral fractures in the lumbar area. She was in the hospital for a month. She has been on Fosamax at one point, but was not able to tolerate it and preferred not to take Actonel. Stop. She has history of cataract surgery in fall of last year on both eyes and remote history of ITP at age 5. Stop. She also has history of tonsillectomy, hysterectomy, vein ligation at age 21. Paragraph. Current medications: venlafaxine 300 mg OD, prednisone 10 mg OD. Paragraph. Allergies: none to meds, allergies, latex. Paragraph. FHX, no history of connective tissue diseases or vasculitis, sister lymphoma. Paragraph. P/E, BP 123/70, no pedal edema, no rashes, no telangiectasia or petechia. Normal heart sounds, no added sounds or murmurs, no bruit on either carotid or subclavian arteries. A lungs clear to auscultation MSK exam revealed no evidence of synovitis. Visual fields were full with no diplopia. Paragraph. Impression. Flora presents with history of increasing fatigue, arthralgias, history of Raynaud's, as well as fairly long-standing history of dry eyes and dry mouth, dry mouth, and positive anti-double-stranded DNA serology. She likely has systemic lupus, and I suggested today treatment with Plaquenil, 200 milligrams twice a day. Benefits and possible side effects were explained, including rare occurrences of ocular toxicity and tinnitus. She was asked to decrease prednisone dose to 5 milligrams per day. I also referred her for bone mineral density, X-ray of the entire spine, as well as hands and wrists, and gave her prescription for Prolia injections. She should also be on vitamin D, 2000 IU per day. She will have additional blood work done, and I will contact her in case of any concerns. Otherwise, I will review Flora at 2 months' time. Canaj, C-A-N-A-J, Edmond, E-D-M-O-N-D. Please address it Dr. Ter Kuili, T-E-R, and separately from capital letter K-U-I-L-E, initial A, paragraph. Thank you very much for referring Edmund, who is 43 year-old man with respect to possible spondylar arthropathy. He developed left-sided upper lumbar area pain intermittently. It's been felt to be related possibly to kidney stone, but eventually that has been ruled out. Then the pain shifted to upper aspect of left buttock, and it has been also present intermittently. He has no history of pain or stiffness in his sacroiliac joints or spine. He is quite active physically and exercises daily at the gym. He has been treated with naproxen, 2 tablets per day, which completely relieved the pain, and right now he is on off that medication. He is currently asymptomatic. He has no history of psoriasis, IBD, or uveitis. Paragraph. Current medications, none. Paragraph. Allergies, none. Paragraph. FHX, mother OA. Paragraph. He is non-smoker. Paragraph. BP 120/17, no pedal edema, no rashes or nail lesions, normal heart sounds, lungs cleared, auscultation MSK exam revealed wall tragus distance 1-2 cm, modified Schober's test 1-5 cm, no evidence of synovitis or dactylitis. Paragraph. He had MRI done of part of the spine, which showed very questionable sacroiliitis. Actually, sorry. He had MRI done of the spine, which showed small erosion with adjacent bone marrow edema on the iliac side of both SI joints, as well as DDD at L4-5 and lumbar facet OA at L2-3 at L4-5. Paragraph. Impression. Edmund has a history of left flank pain and pain over left and possibly pain related to pain at the left SI joint. This does not SI joint stop. His symptoms are really not very characteristic of inflammatory back pain, and therefore he should be investigated further. He was referred for relevant blood work, which will include HLA B27 serology and CRP. And I will also refer him for MRI according to spondyloarthropathy protocol to have a look at to have yet another look at sacroiliac joints. In a person of his age, being active daily at the gym, you can expect to see some inflammatory changes, but erosions are really quite unusual. Therefore, I felt we should have a second opinion about that MRI before committing Edmund to any therapy. Stop. He agreed with this plan, and I will review him again after all tests are completed. Stop. Since he is asymptomatic, I did not suggest any treatment. Stop. Otto O''T-O-O-L-E Wendy W-E-N-D-Y. Please address it to Dr. Galloway, Galloway, initial V, paragraph. Thank you very much for referring Wendy, who is 47-year-old female with respect to possible psoriatic arthritis. Stop. She has history of psoriasis since 1995 following pregnancy. Both brother and father have psoriasis, and grandfather had severe deforming arthritis. Stop. Her psoriasis involves elbows, knees, and possibly toes, and has been also present on her scalp in the past. She was prescribed clobetasol cream. Paragraph. She has been experiencing pain over right fourth DIP and PIP and right third PIP joint. Those joints are stiff but not swollen, and she has no symptoms suggestive of dactylitis. She had in the past heel pain and is known to have history of Osgood-Schlatter disease. Stop. She has been taking occasionally Aleve or Advil, but is not able to tolerate it well. Stop. She is working with her both hands, doing filing and lifting. Paragraph. She has no history of IBD or uveitis. Paragraph. Meds, vitamin D, liquid, and Pantalog daily. Paragraph. Allergies, question mark, cephalosporins. Paragraph. She is menopausal for 2 years. She is a smoker. Paragraph P/E, psoriasis over elbows and possibly nails, normal heart sounds, lungs clear to auscultation. MSK exam revealed tender right fourth and left fifth. PIP joints. None of the joints were swollen. There was no evidence of dactylitis or enthesitis. Paragraph. Impression. Wendy has history of psoriasis for over 20 years. There is no clear evidence of psoriatic arthritis, of synovitis on physical examination, and tenderness in the above joints might be related to osteoarthritis. She was referred for a set of x-rays of hands, wrists, and feet, and was advised to try Celebrex 100 milligrams per day, along with Pantelog and also Voltaren cream. I will review Wendy again in fall of this year. Thank you for referring her for consultation. Stop, Anna Jaroszyńska. Right after physical exam, please insert sentence blood work, negative HLA-B27, normal CBC, creatinine 67, normal ALT, TSH, ferritin, CRP 0. Dempsey, DEMPSEY, Sarah, SARAH. Please address it to Dr. Saeed, S-A-E-E-D, Lina, L-I-N-A. Thank you very much for referring Sarah, who is 44-year-old female, with respect to possible psoriatic arthritis. Paragraph. Sarah has been experiencing extremely severe pain at the tip of her coccyx and also in symphysis pubis. She's scheduled for MRI in Oakville in the next week. She has stiffness that is present across both buttocks and wakes her up at night, and is also present for a few hours in the morning. She is known to have psoriasis for about 5 years and was seen by Dr. Sapra. She has no history of IBD or uveitis. She had colonoscopy a year ago, which was normal. She's a mild smoker for years. Paragraph. She is not. She's experiencing some joint achiness without swelling and no symptoms of dactylitis. There are also no symptoms of enthesitis. Paragraph. She has been treated with Vimovo, but it was not helpful and has been switched to Toradol, which she takes at the dose of 10 milligrams 3 times a day with marginal relief of pain. Paragraph. Allergy, sulfa, penicillin. Paragraph. P/E reveals person with elevated BMI, evidence of psoriasis, normal heart sounds, lungs clear to auscultation. MSK exam reveals tenderness in right hand all PIP joints, as well as left second and third PIP and right second and third DIP joints, as well as medial aspect of left knee. There was no evidence of swelling. She was tender at the tip of the coccyx and symphysis pubis, although not palpated there. Paragraph. Impression, or actually, before we say impression, X-rays of both hips and SI joints comment on some changes within symphysis pubis, possibly symphysitis. Paragraph. Impression. Sarah has history of psoriasis and she may possibly have psoriatic arthritis. She was referred for x-rays of hands, wrists, and knees and relevant blood work. I asked her to stop Toradol and try Celebrex 200 mg BID along with Pantelog 40 milligrams daily. I will follow up with her in mid-April after MRI results are available. Stop. Thank you for referring this patient for consultation. Stop. Anna Jaroszyńska.